Good afternoon, everybody. We are opening session 3. I would like to congratulate organization committee for this outstanding symposium, and I also thanks for invitation. We are chairing this session with my co-chair, Dr. Akarsu. First speaker is Dr. Yusuf Yilmaz. His topic is acute fatty liver and drug-associated fatty liver disease. He is going to present a case to us. Please, Dr. Yilmaz.
Good afternoon, ladies and gentlemen. It's an honor for me to have the opportunity to address such a distinguished audience in this joint meeting. I am Yusuf Yilmaz from the Marmara University in Istanbul, and what I'd like to present to you today is acute fatty liver and drug-associated fatty liver disease. This talk is designed to bring you an up-to-date on these topics and to report an illustrative case. I'd be also delighted if this presentation would act as a springboard for discussion. I start off by reporting a clinical case. A 47-year-old woman with a history of astrocytoma was admitted to the hospital after a syncopal episode for control of seizures. While hospitalized, she was treated with several anticonvulsants, including valproate. Although her seizures were controlled quite well, she presented with unexplained somnolence and confusion. It is widely recognized that valproate can cause hyperammonemia, and this drug can exert this effect by modulating the levels of substrates of the urea cycle. Normally, valproate-induced hyperammonemia is transient and resolves if the drug is withdrawn. And this was exactly what happened in our case. Thus, a key point to remember is that sodium valproate can cause hyperammonemia. As you can see on the screen, the severity of our case was moderate, and while valproate was obviously discontinued, other anticonvulsants were maintained to achieve successful seizures control. The patient was on multiple anticonvulsants when she developed somnolence and confusion. While several reasons could have accounted for a change in her mental status, valproate-induced hyperammonemia was suspected, and as you can see from this slide, the patient's ammonia levels were markedly increased. Withdrawal of valproate led to prompt clinical improvement, and this was paralleled by reduction in ammonia levels. This is, in my opinion, a very illustrative case of the hyperammonemia caused by valproate, a condition that typically occurs without other evidence of hepatitis injury. The pathophysiology is likely linked with the effects of valproate on hepatic mitochondrial function. Let's now deal with drug-induced liver injury, DILI, and specifically, let's take a focus on two important forms of this condition, namely drug-induced steatosis, DIS, and drug-induced steatohepatitis, DISH. These conditions can be caused by a number of different drugs and can present as either acute, potentially lethal disorders, or have a slowly progressive nature. Despite being distinct disorders, the slowly progressive form of DIS and DISH are frequently confused with non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, which are much more common and, by definition, unrelated to drugs. The diagnosis of this requires imaging studies or liver biopsy, whereas DISH can be identified only through liver biopsy. Both diagnoses should be supported by a comprehensive clinical evaluation and through assessment of the drug use. Unfortunately, the monitoring of disease course for both this and DISH remains problematic. In this scenario, the availability of reliable non-invasive biomarkers to monitor disease progression or regression represents an unmet medical need. Among the various forms of DILI, drug-associated fatty liver disease merits comments. As you all know, non-alcoholic fatty liver disease is present when at least 5% of hepatocytes are steatotic in patients who do not consume excess alcohol. Some drugs may induce hepatotoxic lesions that are similar to those found in NAFLD. These lesions can be caused by various therapeutic agents, including several antitumor molecules like methotrexate, 5-fluorouracil, irinotecan, and tamoxifen. Drug-associated fatty liver disease is often reversible when the treatment is stopped. And a specific mention to microvesicular steatosis also needs to be made. This form is characterized by the accumulation of numerous very small droplets in the hepatocyte cytoplasm without peripheral displacement of the nucleus. This is a more severe form of liver injury, and the mechanisms of toxicity is essentially based on mitochondrial dysfunction. One of the drugs that can cause this life-threatening complication is valproate. Let's now briefly examine the pathophysiology of drug-induced steatosis or steatohepatitis. Here, a traditional two-hit model may be proposed, where drugs can act as either the first hit or the second hit. More specifically, drugs can act as the first hit by inducing insulin resistance or promoting de novo lipid synthesis or free fatty acid hepatic uptake, which may in turn lead to accumulation of triglyceride in macrovesicular structures. Alternatively, drugs can also worsen pre-existing steatogenic mechanisms, thus acting as the second hit that drives NAFLD. Drugs can also prompt mitochondrial dysfunction and promote generation of oxidative stress from mitochondrial origin. Drug-induced fatty liver is strongly associated with the duration and dose of medication. There are drugs that typically cause steatohepatitis, others that have been shown to induce accumulation of phospholipids, as well as medications that may worsen an underlying NAFLD. As previously mentioned, we need to pay special attention to the drugs that may cause microvesicular steatosis because this form may be clinically severe and even life-threatening. The mechanisms of drug-induced micro and macrosteatosis are not well understood and are obviously specific to each pharmacological molecule. However, one of the most commonly accepted pathways involves mitochondrial dysfunction, which in turn leads to uncoupling beta oxidation as well as oxidative stress with the production of ROS. Let's now focus on the epidemiology of drug-induced steatosis or steatohepatitis. According to the Drug-Induced Liver Injury Network, steatosis was found in 65 of 249 patients who underwent liver biopsy for DILI, but this finding may be biased by the pre-existing presence of a fatty liver. In general, about 2% of all cases with fatty liver disease are estimated to be drug-induced. Thus, generally speaking, fatty liver is a rare manifestation of drug toxicity. Currently, the only way to identify this lies in the use of imaging studies or liver biopsy. Notably, DISH can be identified only through liver biopsy. Both diagnoses should be supported by a comprehensive clinical evaluation and through assessment of a drug use. Unfortunately, the monitoring of disease course for both DIS and DISH remains problematic. In order to be able to identify a drug as the causative agent of liver steatosis, there must be a strict temporal relationship with its administration, the absence of previous hepatic alterations, and the resolution of the condition after drug discontinuation. Ideally, there should also be the recurrence of the alterations after a drug rechallenge and a plausible biological basis for the development of steatosis. However, we should note that many of the reported associations between drugs and steatosis are difficult to demonstrate because of their weak temporal relationship, the lack of confirmatory rechallenge, and the high prevalence of NAFLD-NASH in the general population. The patient's history of alcohol consumption needs to be truly evaluated, as alcoholic liver disease is an important differential diagnosis of DIS and DISH. We also need to emphasize that the relationship between DILI and NAFLD may be reciprocal. In other words, drugs can cause NAFLD by acting as steatogenic factors. Conversely, pre-existing NAFLD could be a predisposing condition for certain drugs to cause DILI. Importantly, the use of multiple drugs in obese patients may potentiate the association between obesity and DILI. Another concept that should be emphasized that DIS and DISH may share histology and imaging features that are similar to those of NAFLD and NASH. However, the natural history, pathophysiology, and prognosis of these conditions are generally different and may depend on the drug, length of exposure, individual susceptibility, and a number of other factors. Again, as previously mentioned, diagnostic sensitivity and specificity of the current non-invasive modalities remain suboptimal, and the use of liver biopsy is not without known caveats. Accurate non-invasive tests based on objective, specific, and definable levels of validated biomarkers will be essential in the future to improve and standardize the diagnosis. In a recent paper by Gervason and co-workers, the authors reviewed several potential biomarkers of DIS and DISH, including microRNAs. It is important to emphasize that these markers need to be studied also in relation to their differential diagnosis from NAFLD. Thus, they should be able to distinguish this DISH from common NAFLD. In this scenario, a recently published study by Liu et al. Has identified circulating microRNAs that may be unique to DIS or DISH and that are not expressed in other etiologies of steatosis. This should help avoiding the possible misdiagnosis of the primary NAFLD in a patient with DIS or DISH. Of course, these interesting results need independent replication. From a diagnostic standpoint, recent pathophysiological advances hold promise to provide much-needed surrogated non-invasive biomarkers to detect DIS and DISH progression or resolution without the cumbersome use of liver biopsy. The paradigm shift towards an earlier non-invasive characterization and diagnosis will be crucial to prompt recognition and follow up this condition. As a final point, I'd like to provide some remarks related to the clinical management of patients with DISH, which are summarized in the slide. that also completes my presentation. If the implicated drug has already been discontinued at the time of diagnosis, it should not be reintroduced. If patients are still on the drug, stop the drug whenever possible, and please consider alternative forms of therapy if available. If not, the risk and benefits of continuing the drug versus stopping it should be carefully weighed. Components of metabolic syndrome should be considered risk factors for the occurrence and the degree of default in patients treated with tamoxifen and methotrexate.
Thank you very much for this excellent presentation, Dr. Yilmaz. My co-chair is going to rule the session. Dr. Akarsu, please invite the other speaker.
Ses kapalı.
Microphone is not open.
Okay. Hello,
Yes.
everyone. I would like to thank you, organizing committee, and we will move on. The next speaker of the session is Professor Yasemin Balaban from Hacettepe University in Ankara. She is going to talk about liver toxicity due to treatment for COVID. Please, Yasemin Balaban.
Can you see my slides? Good afternoon, dear chairs and colleagues. Welcome to our joint meeting with TASL and BASL. I will try to present liver toxicity due to treatment of COVID. I have nothing to disclose related to this presentation. As you all know, COVID was identified a new etiology of pneumonia outbreak in China in July 2020. But later on, within 2 months, it was evolved to a pandemic affecting all over the world. Until March 2021, there is more than 110 million people affected by this pandemic, and almost 2.5 million died. When we look at Turkey, there are 207 million cases and about 30,000 deaths. This table shows the daily incidence of COVID all over the world. As you know, although the pandemic starts from Asia, it affects the patient mostly in America and Europe. And still it's ongoing. You can see the first and second waves of pandemic. And on March 18, it is affecting more than 100,000 people in Europe and America. When we compare the Turkey and UK, although the population of UK is less than Turkey, total number of the patients and the total number of deaths was higher in UK. However, the UK achieved a zero number of deaths recently, although the incidence of COVID cases start to climb up in Turkey. When we look at the virology, coronavirus is a family of virus. It's a zoonotic virus, and it's transmitted from animals to human being in 2002. And the first member of this family was SARS, and it caused a local epidemic with mortality rate of 10%. 10 years later, second member come up, and it was the Middle East respiratory syndrome virus with very high mortality rate, but it also disappeared very soon. However, coronavirus causes very high mortality rate, and it's estimated that the cost of ending up the current pandemic is around $8 to $16 trillion. However, we can prevent the next pandemic with less than this money, and it can be prevented by $40 to $80 million. But in order to achieve that, we need to make very important precautions, like the environmental susceptibility. We should decrease the air pollution. Also, we should create areas for animals to live. SARS is a new member of this family. It's a beta-CoV2 virus. It's an RNA virus with envelope and single-stranded without any capsid. It has very large genome with 4 structural proteins, namely S, E, M, and N proteins. And the S protein interacts with ACE2 receptors during the infection of a cell. When we look at, as you all know, ACE2 receptors is expressed highly on type 2 alveolar cells, so the infection starts from the lung. However, the studies with hepatoma cell lines revealed that COVID can also infect the hepatocytes, and you can clearly see the spike proteins within the cytoplasm of hepatocyte. The single-cell analysis from the liver tissue revealed that ACE2 is in fact as strongly expressed in cholangiocytes as in the alveolar cells. Although it's less, it is also expressed in endothelial cells and hepatocytes. The interesting point is that although ACE2 receptors are highly expressed in cholangiocytes, it doesn't cause cholestatic liver injury. So it's speculated that cholangiocytes are a reservoir for virus replication and similar to enterocytes. And so this may be another way of spreading of the infection. As we look at how the COVID pandemic affect the liver disease, it caused a decrease in hospitalization for the cirrhosis complications. However, the hospitalized patients with cirrhosis have much more severe disease, and the time for HCC diagnosis is prolonged, and alcohol consumption is increased. Liver transplantation sharply decreased, as well as the upper endoscopies and ultrasonographies, which are very important for detection of complications in cirrhosis. COVID mortality ranges from 80% to 21% in healthy population, but if the patient has cirrhosis, parallel to severity of cirrhosis and parallel to severity of COVID, mortality increased from 22% to 90%. So presence of cirrhosis is very important factor for determining mortality. When we look at the organ donation and transplantation rates, both of them declined sharply after the first wave of pandemic started. Although then it starts to increase, the second wave of pandemic also caused decrease in them. So this is very important pressure on our survivals in patients with cirrhosis. The known risk factors for COVID is older age, hypertension, diabetes, and obesity. However, it's suspected that liver transplantation, cirrhosis, and liver cancers are also risk factors for the COVID. When we look at the liver injury among the COVID patients, starting from the Chinese report, it's reported that between 6 to 35% of patients have elevation in liver enzymes on hospital admission. And in a recent meta-analysis comparing the Chinese reports with the American reports, the ALT and AST elevation is seen in patients between 25 to 50%. Please note that the patients from America has higher rates of liver enzyme elevation correlated with the higher mortality in America. In the summary, liver enzyme biochemistry abnormalities are very common in patients with SARS-CoV-2 infection, ranging from 15% to 65%. But it's usually mild. And the important point is AST elevation, since AST is usually higher than ALT, and but not positively correlate with creatine kinase muscle enzymes, and not with inflammation markers. So it needs to differentiate from the alcohol-related liver disease, ischemic hepatitis, and cirrhosis. In contrary, ALT is often correlated with the inflammation markers. Liver injury usually seen during the 2nd to 3rd weeks of the infection progression, and liver enzymes, ALT, AST, ALP, and total bilirubin are correlated with the mortality. Especially AST has very high correlation, 14 to 5 hazard ratio. When we look at the cause of liver enzymes, there are several causes triggering the liver injury, like underlying liver disease, sepsis, ischemia, or non-hepatic sources of liver enzymes. However, 3 major pathogenesis directly related to COVID infection is direct viral mediated liver injury, host immune response affecting the liver, and drug-induced liver injury. I will try to focus on drug-induced liver injury. I will present a case, 58 years old male. He had history of NASH from the age of 38. And except for lifestyle changes, including diet and exercise, no further investigation was done for the diagnosis of treatment of liver disease. On November 2020, he developed cough, dyspnea after exposure to a patient with COVID-19. His test was positive with normal thorax CT findings. And he was initiated acetaminophen, favipiravir, and oxapar as a standard doses as home treatment. But he had persistent fever and dyspnea, and second thorax tomography revealed development of ground glass densities, so he was hospitalized. His past medical history revealed the hyperuricemia and some changes in coronary arteries. So he was using allopurinol and aspirin. No significant family history. His vital signs were normal, but he had mild hypoxia with obesity. Her laboratory test was in accordance with the acute COVID infection, and his liver enzymes elevated, mainly cholestatic type, but his bilirubin and INR levels were normal. His metabolic parameters reflect the NAFLD, but surprisingly, ANA was also positive at 1 to 320 titer. When we look at the liver enzyme progression after COVID infection, his cholestatic enzymes increased sharply. So the decision point for us was that what was the etiology of liver enzyme elevation? Does this patient needs further evaluation for liver disease? Should antivirals or other drugs be modified or stopped? As you all know, DILI has several forms. It may be directly toxicity related, or there may be an adaptive response in liver enzymes, or it may be a progressive form with idiopathic reactions. And the type of the DILI is determined by both drugs and host factors. So, when we see a patient with DILI, we should evaluate the severity of liver enzyme elevation as well as type of liver injury. When we look at the stages of the COVID infection, it has 3 stages: early stage with infection signs, then pulmonary stage with dyspnea, then hyperinflammation phase with systemic findings. And depending on the stage of disease, we have several options, although they are not proven to be effective for the treatment. So NIH updates the treatment guideline. The last update was on March 5. And NIH states that this is a living document expected to be updated upon as new clinical data acquired. So the first question, whether COVID is a risk factor for development of serious adverse drug reaction. This is a Spanish study. They compared the liver adverse drug reactions in patients with and without COVID infection, and about 1/3 of patients were having COVID infection. So they found that the incidence rate of severe adverse drug reaction is about 5-fold increased in COVID patients. There are several types of adverse drug reactions, including hepatotoxicity, and the hepatitis was twice as common in COVID patients than the non-COVID patients. The drugs most frequently related with these reactions are tocilizumab, dexaketaferophan, azithromycin, lopinavir, ritonavir, dexamethasone, and chloroquine, hydrochloroquine. As I told you, there are several options for COVID treatment. In fact, none of them is working very well. But meta-analysis report a pooled incidence of DILI in COVID patients in 1/4 of the patients. So these patients are old patients, and they are using combined medications, and there are underlying other disease. So all these make them prone to DILI. In this review of literature, ritonavir, lopinavir, remdesivir, and imuphenavir were related with hepatotoxicity. I should mention acetaminophen. Although it is the most common cause of DILI all over the world, acetaminophen hepatotoxicity in patients with COVID has not been well studied, and we are not sure that the acetaminophen toxicity is increased among COVID patients. For the sake of time, I will skip these slides. I would like to summarize this study, this very nice study. They studied 116 COVID drugs in 30 different kinds of human tissues for the adverse reactions involving the liver, kidney, lung, and nervous system. And they validate their findings according to clinical data and pharmacovigilance analysis. They found that alimentary tract is involved in 5% of COVID patients, and ibuprofen and enoxaparin are the main risk factors for the DILI among COVID patients. Also, they showed that sirolimus, folic acid, and cholecalciferol is also associated with the liver injury. When we talk about DILI, we should not forget the drug-drug interactions, and this is very nice. Very nice online page for checking the drug interactions. It's very valuable. According to type of drug and antivirals, we can check the risk. I want to emphasize that even anti-COVID drugs can interact with each other, let alone the immunosuppressive treatments in transplant patients. ASLD recently published a guideline for evaluating liver enzyme elevation in COVID patients. So if a patient has elevation in liver enzymes, first viral hepatitis should be checked. But review medication is very important, and please try to avoid the imaging techniques because of virus contamination spread. And if the patient has stable liver enzymes, there is no just you can follow the patient. But if the liver enzymes worsens, removal of hepatotoxic drugs, including antivirals, should be discussed. For our patients, the drug treatment was continued without any modification. He recovered without needing steroid treatment and discharged after 2 weeks, and he was recommended to be on diet and exercise. At the first month visit, he lost 3 kilograms of body weight, and ALT, AST level almost normalized. And his glucose levels also normalized, but he has persistent ANA positivity. We plan to do multiparametric MRI for the management of NASH. Key points I would like to say, we are at the just anniversary of ongoing COVID-19 pandemic, and COVID-19 is associated with liver injury, although we don't understand the underlying physiology very well, and it's a prognostic marker. The increase in liver enzymes is most of the time mild and moderate, and usually secondary to the associated conditions of COVID-19. DILI was more common early in the pandemic due to use of experimental therapies, but DILI and drug interactions are important obstacle in management of patients with COVID-19, since they may cause acute on chronic liver failure in patients with cirrhosis, or drug interactions and toxicity may cause problem in transplant patients, such as acute liver rejection. Thanks for BASL and TASL for the meeting, and thanks for your attention.
Professor Balaban, thank you for a great talk. We'll answer the questions end of the session. Professor Şimşek, you can present the last speaker, please.
Thank you. Our second speaker is Dr. Sınganayagam. I would like to welcome to him. His topic is the checkpoint inhibitor-induced liver injury. Please, Dr. Sınganayagam. Microphone yours.
Hello, I'm Dr. Arj Singhnigam. I am a senior lecturer and consultant hepatologist at St George's University of London and St George's NHS Foundation Trust in South London. It gives me great pleasure to speak about checkpoint inhibitor-induced liver injury. Thank you to the BASL and TASL organising committees, and in particular Professor Guru Aital for inviting me to speak. In this talk, we will touch upon the basics of cancer immunobiology, the currently used checkpoint inhibitors, their uses and function, their toxicities, and then focus on checkpoint inhibitor-induced liver injury, colloquially known as CHILI. In particular, we're going to look at the grading, incidence, histological features, possible mechanisms, and treatment. So the normal immune system is capable of fighting infection, repairing damaged cells and tissues, and demonstrates self-tolerance such that we don't have autoimmunity and tissues are protected in responding to pathogenic infection. This balance is referred to as immune homeostasis and involves a regulated and fine-tuned immune response. In the case of T cells, part of the adaptive immune system, they recognize antigen via the T cell receptor, which presented to them by antigen-presenting cells using the MHC system. In the case of cancers, all cancers exhibit genetic and epigenetic alterations, such as they provide a diverse range of antigens called tumor-associated antigens, which the immune system can use to distinguish tumor cells from normal cells. T cells recognize tumor-associated antigens both in lymphoid tissue and in the tumor site. They undergo a clonal selection of antigen-specific cells, activate and proliferate in secondary lymphoid tissue, traffic to the tumor site, and kill antigen-expressing cells via CD8 positive effector T cells. There's recruitment of other immune cells, including CD4 helper cells and myeloid cells, through the production of cytokines and membrane ligands. The strength and quality of T-cell immune responses is regulated by co-stimulatory and inhibitory signals. One of the inhibitory signals are immune checkpoints. These are ordinarily important for the maintenance of self-tolerance and to prevent collateral tissue damage. There are three main checkpoints of relevance in current practice. Two are receptors, CTLA4, which stands for cytotoxic T lymphocyte-associated protein 4, and PD-1, programmed cell death receptor 1, and PD-L1 is the ligand for that receptor. CTLA4 and PD-1 are expressed on T cells, whilst PD-L1 is generated by tumor cells. CTLA4 works in the priming phase, mainly in lymphoid tissue, and is induced on antigen recognition, where antigens presented by antigen-presenting cells, such as dendritic cells, to the T cell receptor. This generates CTLA4 within the cell, and intracellular vesicles containing the protein are externalized to the cell surface of CD8 positive T cells. They counteract the co-stimulatory receptor CD28 by competing for their common ligand, CD80 or CD86, collectively known as B7 proteins. There's also down modulation of CD4 positive T helper cells and an expansion of the immunosuppressive T regulatory cell subset. PD-1, PD-L1 works in peripheral tissues in the later effector phase. Engagement of PD-L1 and PD-L2 on PD-1 results in kinase inhibition and leads to the suppression of T cell activity. There is also an effect of increasing T regulatory cell proliferation. PD-1 is also expressed on B cells, NK cells, monocytes, and macrophages, which also exhibit immunosuppressive activity. The action of tumor PD-L1 and PD-1 results in tumor evasion, and so inhibitors increase the anti-tumor immune response. In this graphic, it summarizes how the current checkpoint inhibitors work. CTLA-4 inhibitors include ipilimumab and tremelimumab, and only the former is regularly used in clinical practice. PD-1 inhibitors are pembrolizumab and nivolumab, and PD-L1 inhibitors, the latest are atezolizumab, and avelumab, and durvalumab. So checkpoint inhibitors are monoclonal antibodies which have specific binding to the receptors or ligands. They are delivered as an intravenous infusion. However, aside from CTLA-4 and the PD-1, PD-L1 axis, there are in fact numerous checkpoints, and so this field is probably just in its infancy, with many other drugs undoubtedly in the pipeline. They all function to augment anti-tumor immunity, and the existing ones have been shown in clinical trials to improve survival in advanced, inoperable and metastatic cancers. Anti-CTLA-4 ipilimumab was the first immune checkpoint inhibitor approved in 2011. It's a human IgG1 monoclonal antibody. Early clinical trials demonstrated an almost doubling of the 1 and 2 year survival in patients with unresectable or metastatic melanoma. The anti-PD-1 axis represents the second generation, and pembrolizumab and nivolumab have application in a wide range of malignancies that includes non-squamous and metastatic squamous non-small cell lung cancer, advanced renal cell cancer, Hodgkin's lymphoma, and locally advanced or metastatic urothelial carcinomas. The spectrum of PD-L1 targets is quite low, just urothelial tumours, non-small cell lung cancers, and metastatic Merkel cell carcinoma. Unresectable hepatocellular carcinoma has recently been added to the list for atezolizumab in combination with bevacizumab. The efficacy of these treatments is variable depending on gene overexpression, the type of mutations, and the mutational burden in tumour cells. So genetic sequencing is important to determine the favourability of response to these agents. Of course, combination therapies can also be used. Ipilimumab and nivolumab are commonly used as combination therapy. However, despite their promise, checkpoint inhibitors are associated with immune-related adverse events, which you might expect since it alters the immune homeostatic balance. These toxicities have autoimmune-like characteristics due to reduced self-tolerance. They can involve multiple different organs, but most commonly the immune-related adverse effects involve the endocrine system, the skin, heart, gut, and liver. And of course, hepatotoxicity is what we're most interested in here. It is considered a drug-induced liver injury. However, it is indirect in that the injury comes from immune augmentation rather than direct toxic effects on the liver. Conventional drug-induced liver injuries tend to have direct or idiosyncratic effects. This may be of particular relevance, particularly in the world of hepatocellular cancer treatment, given the recent trials supporting atezolizumab in combination with bevacizumab for advanced HCC, since hepatotoxicity may result in decompensation in a liver that's already predisposed to it. This is a table which provides you an example of all the potential immune-related adverse effects, and as you can see, there are numerous. So, in terms of the grading, the grading of hepatotoxicity uses the common terminology for adverse events, CTCAE. This grading system is used in all cancer clinical trials to define hepatotoxicity. It uses the commonly performed liver function tests, aspartate transaminase, alanine transaminase, the gamma-glutamyl transpeptidase, and the total bilirubin. And it looks at the magnitude of change compared to the upper limit of normal of these enzymes. The grades of injury are graded from 1, which is very mild, to actually 5, which is death, but 3 is severe and 4 is life-threatening. And you can see the classifications on the table. Severe is greater than 5 times the upper limit of normal for any of the liver function tests, and more than 3 times the upper limit of normal for total bilirubin. Of course, you can get combinations of these, and the numbers don't always reflect the clinical picture. What about the incidence? So the overall incidence is quite variable in the literature, but tends to be in the 0.7 to 16% region. The injury is often asymptomatic and identified on monitoring blood tests, and typically it occurs 6 to 14 weeks after initiating checkpoint inhibitor therapy. Many patients may have abnormal pre-treatment liver enzymes due to metastases, comorbidities, or concomitant medications. And what increases the risks? Well, concurrent traditional chemotherapy increases the risks. Then the type and dose of the checkpoint inhibitor affects the risks. So PD-1 inhibitors are low risk, PD-L1 and standard dose CTLA-4 have intermediate risks, and high risks are the combination treatments, for example, the nivolumab and ipilimumab combination, and high dose CTLA-4, i.e. in the 10 mg per kilogram dosing. The injury can be hepatocellular, cholestatic, or mixed. Reports of the commonest varies in the literature. You can get fulminant liver failure, which is rare but possible, and death is very rare, occurs in 0.05%. The risk of checkpoint inhibitor induced liver injury is also higher if there are other either preceding or simultaneous non-hepatic organ toxicities. Histologically, there's an autoimmune-like hepatitis with a granulomatous predominance with the CTLA-4 hepatotoxicity, and a lobular hepatitis with perivascular histiocyte-rich infiltrates with the PD-1, PD-L1 injury. Liver biopsy may be considered for grade 2 and above, but may only really be useful if there's diagnostic uncertainty about the cause of deranged liver function tests. Its routine use is debatable. In addition to the risks of biopsy, there are no pathognomonic findings for checkpoint inhibitor-induced liver injury, and it does not usually influence the management. The mechanism of hepatotoxicity is an unexplored area, but colleagues of mine in my previous laboratory group at Imperial College London have a paper in press in the Journal of Hepatology on mechanisms of hepatotoxicity in checkpoint inhibitor-induced liver injury. There they evaluated myeloid and lymphocyte subsets in patients with hepatotoxicity and compared to those patients that didn't have hepatotoxicity and healthy controls. And in the checkpoint inhibitor-induced hepatitis, there was activation of peripheral monocytes and CD8 positive T cells, increase in the membrane-bound and soluble CD163, and that is a marker of monocyte and macrophage activation, increase in monocyte tissue homing marker CCR2, and in liver biopsy samples there was co-localization of CD8 positive T cells and CCR2 positive CD163 positive macrophages where they formed inflammatory aggregates. So these, both the CD8 positive T cells and monocytes in the periphery are activated and home to the liver where they form these aggregates and cause inflammation and damage. Pre-existing liver disease doesn't preclude initiation of checkpoint inhibitors, and there's no evidence it increases the risk of toxicity, but may, of course, influence the type and dose of the checkpoint inhibitor to be used. Of course, one would screen for liver diseases prior to the initiation of any chemotherapy or immunotherapy, and that includes a viral hepatitis screen. Liver function tests are monitored prior to each infusion, and if a mild abnormality in the liver function test is detected, then the frequency might increase to, say, weekly. Grade 1 hepatotoxicity doesn't warrant any cessation of treatment. However, grade 2 injury should prompt holding of checkpoint inhibitors and monitoring of liver function tests more frequently, perhaps every few days. One should also perform autoantibody profiling and liver imaging. There is, of course, prospect of biliary obstruction, liver metastases, the development of liver fibrosis or cirrhosis, and viral reactivation or de novo infection, which ought to be considered in the differential diagnosis of any abnormal liver function tests that develop during a checkpoint inhibitor therapy. In terms of treatment, there is no consensus on this. There are multiple international guidelines, and there is variability in the centres that prescribe checkpoint inhibitors. Certainly, if there is grade 2, the recommendation is to hold the checkpoint inhibitor, and in some centres they would start oral steroids, prednisolone for example, at 0.5 mg to 1 mg per kilogram per day. Some centres don't start steroids since there's been an observation that 50% of patients will resolve without steroids, and additionally steroids are associated with an 8-fold increase in infection. Once the liver function tests improve to the grade 1 region, provided that steroid dose is less than 10 mg per day, then the checkpoint inhibitor can be restarted and the steroids can be tapered over a 1-month course. For grade 3 or 4, the patients should be admitted and the checkpoint inhibitor is generally recommended to be permanently discontinued. For grade 3, some recommend IV methylprednisolone at 1 to 2 mg per kilogram per day, and others would initiate only prednisolone at 0.5 mg to 1 mg per kilogram per day, if there was no improvement over the first 3 to 5 days after checkpoint inhibitor discontinuation. Grade 4 hepatotoxicity, the general consensus is that you definitely should treat with IV methylprednisolone. Some recommend 1 mg, some recommend 2 mg per kilogram per day. Budesonide could also be considered, but there is limited evidence. It may represent a strategy to continue checkpoint inhibitors in the future with continued use. So re-challenge is a dilemma, and one must balance the risks of not continuing the checkpoint inhibitor, which may mean disease progression, against the ongoing treatment and the risks of recurrent toxicity. There are many cases where hepatotoxicity doesn't recur in grade 1 or 2 hepatotoxicity, where a re-challenge has occurred. Decisions on immunosuppressive treatment are also influenced by other organ toxicities, which may be more steroid responsive. In terms of steroid refractory hepatotoxicity, then other immunosuppressants have been used. MMF, azathioprine, cyclosporin, ATG, and a variety of other immunosuppressants have been used in various centres. Infliximab is not recommended due to the risk of autoimmune hepatocellular injury with it. One should also consider giving prophylactic antibiotics. Generally speaking, second line seems to be MMF or azathioprine, and if there's no improvement with that, third line tends to be tacrolimus. This slide depicts the algorithm, and there is a difference in international guidelines. The key point is that treatment should be individualized and decisions should involve the multidisciplinary team. So in conclusion, checkpoint inhibitors improve survival in a wide range of cancers, and there are many more targets and drugs in the pipeline. The current targets are CTLA-4 and PD-1, the PD-L1 axis, and checkpoint inhibitor-induced liver injury occurs in about 0.7 to 16% of the time. It's more common with CTLA-4 inhibitors, and especially if you give a higher dose and in combination treatments. Autoimmune and granulomatous hepatitis are the histological and clinical phenotypes seen. Steroids are used to treat grade 2+, but increasingly initiation is either avoided or delayed. Second line treatments include MMF or azathioprine, and third line tends to be tacrolimus, though many other agents have been used in a variety of different settings. In terms of future work, so as I said, there are several checkpoints such as TIM3 and LAG, and there are other immune inhibitory pathways that could represent targets for therapy. For example, indoleamine 2,3 deoxygenase is a potential pathway. As a consequence, there'll be many more toxicities and many mechanisms to consider. Budesonide could be used instead of prednisolone, and it may be preferable since budesonide has an extensive first-pass metabolism in the liver and therefore low systemic side effects, and indeed, of course, is used in autoimmune hepatitis. Some advocate its continuous use to permit reintroduction of checkpoint inhibitors, even in high grades of hepatotoxicity. Of course, this requires further evaluation. Steroid dosing needs further study, and this includes whether steroids are needed at all due to the high rates of spontaneous resolution reported in some studies. Other agents, such as IL-6 inhibitor tocilizumab, which is currently being used to treat systemic inflammation associated with COVID in some centres in the UK, could be trialled. N-acetylcysteine and ursodeoxycholic acid, the latter for cholestatic predominant liver injury, are also possibilities. And there is a UK study called the Chile Study, which is run by Professor Guru Aithal and his fellow at the University of Nottingham, and we are privileged to be a participating centre at St George's, and this study will run over the next few years. Many thanks for letting me speak. I hope this was an informative talk, and I look forward to any questions you may have.
Thank you very much for this excellent presentation. For this new topic. Thanks again. There are several questions to the speakers. The first question is coming from Dr. Fatih Eren to Dr. Yilmaz. The question is, sometimes mild transaminase elevation can be observed during long-term use of valproate. How to manage it, and what are the types of hepatotoxicity that can be observed with valproate therapy? What's your answer, Dr. Yilmaz?
Okay, thank you for the questions. We know from prospective studies that 5 to 10% of the patients develop ALT elevations during long-term valproate therapy. We know that this medication can be used also for bipolar disorders and migraine headache also. But these abnormalities are usually asymptomatic and can resolve even with continuation of the drug. But we should be aware that also there are more than 100 fatal cases of acute or chronic liver injury due to valproate have been reported in the literature. For this reason, I will mention 3 clinical distinguishable forms of hepatotoxicity besides simple aminotransferase elevations can occur with valproate. The first syndrome is hyperammonemia with minimal or no evidence of hepatic injury, as I mentioned in my presentation. The second form of injury from valproate is an acute hepatocellular injury with jaundice, typically accompanied by hepatocellular or mixed pattern of enzyme elevations. And valproate regularly listed as a cause of drug-induced acute liver failure. The last one, the third form of hepatic injury due to valproate is Rhea-like syndrome described in children on valproate who develop fever, lethargy, suggestive of a viral infection, followed by confusion, stupor, and coma, with raised ammonia levels and marked ALT elevations, but normal or minimally elevated bilirubin levels. And we can see also metabolic acidosis in this child patient group. And valproate may simply be aspirin-like agent capable of triggering Rhea syndrome. We should know the characteristics of the drugs to evaluate the patients very well. All 3 forms of hepatotoxicity have features of mitochondrial dysfunction, and liver histology demonstrates microvesicular steatosis with variable amounts of inflammation and cholestasis. As I shown in my slides, the TASL recommend that if you face a patient with anicteric hepatoencephalopathy, we should remind that the patients have the drug-related mitochondrial dysfunction, and we may see the patient in hypoglycemia, hyperammonemia, lactic acidosis, and metabolic acidosis.
And the other question is to Yusuf Yilmaz. Methotrexate is widely used in the therapy of psoriasis. How to screen or monitor methotrexate-induced liver fibrosis in this patient group?
Yes, methotrexate is widely used not only in psoriasis, it's also used in rheumatoid arthritis patients. Methotrexate is well known to cause serum aminotransferase elevations. Approximately 5% of the patients have elevations greater than twice upper limit of normal, and long-term therapy has been linked to development of fatty liver disease, steatohepatitis, fibrosis, even cirrhosis. But with low dose regimens, I mean that 5 to 15 milligrams, a single dose weekly with folate supplementation, significant fibrosis is very rare with long-term use. But as mentioned previous session by Professor Cemal Erçin, significant fibrosis is mostly seen in patients with high risk factors, such as the patient may use excessive alcohol use, or the patient may have obesity or diabetes or underlying other chronic liver disease, for example, hepatitis B. The American guidelines stratify patients to low risk and high risk based on the risk factors, as I mentioned before. They do not recommend liver biopsy at the beginning if the patients have low risk factors. But in case of high risk factors, for example, the patient may have diabetes or obesity and using methotrexate, at the beginning, ASLD was recommend liver biopsy and then repeatedly liver biopsy if the cumulative dose reached 3 grams or 4 grams. But the British guidelines, I think this is published in 2016, it's against liver biopsy. The dermatologist monitor the patients with measuring procollagen type 3 and terminal peptide. If is more than 8 milligram per milliliter, we need to evaluate the patients in more details. But in my clinical practice, I use FibroScan transient elastography to evaluate significant fibrosis or advanced fibrosis or cirrhosis if the patients have mild elevations, mild transaminase elevations, or totally normal. We know that it is also established that permanent transaminase levels doesn't exclude the cirrhosis. In this case, in my clinical practice, in my hospital, when the patient referred to my clinic from dermatology department, I perform FibroScan. If FibroScan predicts at least significant fibrosis according to Metavir F2, I suggest to dermatologist to stop the medication or change to alternate medication. If they insist on the methotrexate, for example, it's very cheap and cost-effective and very effective drug. In this case, I suggest them to perform liver biopsy, and we decide according to the liver biopsy characteristics.
Thank you.
Do you recommend non-invasive test before initiating the therapy in these patients?
In case of methotrexate-induced liver fibrosis, there is no validated biomarkers. For example, we have many biomarkers, for example, FIB4, NAFLD fibrosis, or ProCUH, like this for NAFLD or viral hepatitis, but there is no enough data for methotrexate. But we can use procollagen and terminal peptide, but we should be cautious in case of arthritis because inflammation increase the value unrelated with the liver fibrosis. We should be cautious in this case.
Thank you.
There is another question. There are patients with abnormal liver function test and long-term anti-epileptics. What are the chances of serious consequences and when to consider stop and swapping Trendol?
As I mentioned before, if the patients have mild elevation of ALT, for example, 1 to twice upper limit of normal, we may close follow-up the patients if, of course, total bilirubin normal, INR normal, and the patient is asymptomatic. We may follow the patients, and we may to elucidate the underlying other reasons of the elevations of the transaminases. For example, the patient may have fatty liver disease. the patients may have a viral hepatitis, not directed to change to another agents. We just follow, and we need to know the drug characteristics also.
One question from Dr. Günçer. So it's a very common question in general. Tamoxifen is used for breast cancer and sometimes we cannot stop it. What do we have to stop it? I add another question to it. Do you use the orthodeoxycholic acid in those patients when you couldn't stop it?
Okay, this is also very good questions. And the previous speakers also mentioned about it. I think the Professor Fulya. Tamoxifen increases the NASH risk nearly 8 times, but it increases the fatty liver risk twice. But it is related with the comorbidities, for example, the obesity or diabetes. If we control the comorbidities, if the patients follow our advice on lifestyle modification, we may follow the patients. But in my clinical practice, I also use FibroScan again. And if the patients have advanced fibrosis, I talk to oncologists they have be able to change the tamoxifen or not. Otherwise, if the patient doesn't lose weight and continue to study the drug, the progression to cirrhosis would be faster. I warn the patients and his physicians.
The other question from GRU to Yusuf Yilmaz. Please elaborate on the study design and methods of the paper that you presented investigating biomarkers of DISH, distinguishing them from NAFL and NASH.
Okay, I think Professor Guru mentioned the Liu et al.'s study. Yes, I only summarize the schema on the slide, but they hypothesized that distinct molecular circuits of microRNA-associated target genes and search for mechanistically linked serum and tissue biomarkers that would distinguish between these and human NAFLD of different grades. And they analyzed more than 800 rat hepatic whole genome data for 17 steatotic drugs, and they identified more than 150 distinct microRNAs targeting more than 70 drug-induced steatosis-regulated genes. Subsequently, genomic data of cases of human NAFLD and healthy controls were compared to serum MIRNA profiles. And they consequently identified some microRNAs may differentiate drug-induced steatosis from primary NAFLD.
Thanks.
And go ahead.
Oh, okay. And the next question from Müjdat Zeybel to Professor Balaban. Lopinavir and ritonavir combination was recommended by national guidelines in Turkey. Have you observed any acute liver failure due to this combination or other COVID-related drugs?
Thank you for the question. Hacettepe is a COVID center, but we have limited number of beds. So our experience with COVID patient is limited. For me, I have no experience with the antiviral related acute liver failure or severe liver injury. Most of our patients has liver toxicity, but they were mainly related with the secondary causes, and they recovered when the patient get well.
I didn't heard about that too.
Okay. Another question from Dr. Kuru. Here are in Chile due to drugs. Granuloma is indicator of good prognosis. Is it likely to be the same in Chile? Dr. Ash, are you here?
I think he is mute.
Do you want to repeat the question? Can you hear me? Seems that he is disconnected. And
Can you hear me?
Yeah.
Yes, we can.
Okay. Sorry,
Yes.
my headphones aren't
No
working.
problem.
Thank you very much for the question. I don't think there's enough data there because obviously this is a rare condition and biopsies are also performed rarely. I don't think there's enough data about granulomas to hepatitis on biopsy predicting prognosis. And also there's a huge variability in how there's a huge variability in the condition itself because of the underlying cancer, the type of treatment, the combination of treatment, the dose used, the duration, and there's also variability in how it's treated, whether it's treated with steroids, second-line therapy, dosing, etc. So I think that there needs to be more studies, and Professor Eichel is doing that study, so that's very good. And hopefully we will be doing biopsies as part of that study, and hopefully we'll be able to identify whether there's any prognostic histological features.
Dr. Akarsu asking two questions to you. Is liver biopsy necessary before starting steroid therapy? That's your first question.
I don't think so. Again, the practice is variable. Biopsy is not entirely necessary. I think the only indication really to do the biopsy is if there is diagnostic uncertainty. For example, if you think it's metastatic disease burden or you think there's some other disease that's cofactored.
Second question, is there a place for everolimus for steroid non-responders?
I don't think that's been looked at. I haven't seen any literature in which they've looked at everolimus. They've certainly used tacrolimus. So perhaps there have been a few case reports on that, I don't know, but it's certainly not commonly used.
Dr. Edelman asking that 5 days is enough time for treatment response, especially for AZO or MMF. Time 5 days is enough for the treatment response, especially for AZO and macrophenolate.
I don't think there's a clear, definite time course. It depends on how the liver function tests improve over time. On average, I think it takes about a month for the liver injury to completely resolve, but obviously it depends on the grade of the liver injury.
Is there any questions from the audience and from the speakers? It seems that we are going to the end of this session. Myself and Dr. Akarsu, we would like to thank your contribution during this session. All of you, thank you very much and welcome.
Good night. Bye-bye.
Thank you.
Bye-bye. Good night. Thank you, everybody.